So my today's topic is the fluid therapy for patients in ICU, which shoots the patient bed. The IV fluid is the most common intervention that a patient receives, probably within minutes when he or she comes or gets admitted to the ICU. But we often don't use fluid very cautiously. We must appreciate that fluid is a medicine. Yes, it's a drug. So we should use right fluid for the right patient in a right dose for the right duration, just like an antibiotic. So why it is so? Fluid is not something very innocuous. It really hurts if we don't use it properly. And if we broadly categorize it into three parts, it basically causes volume overload, sodium overload, and chloride overload. The patients often come to us in volume overload. The first two categories, that is the hypervolemia and the overhydration, is not very difficult to treat. But the difficult is the capillary leakage because it causes interstitial edema. And what is even more difficult is the sodium overload. Our kidney is very apt to conserve sodium, but it's not so efficient in handling the sodium overload because of this is our evolution pattern. We are not supposed to take a high sodium diet. That's why the kidneys are not adapted to handle a huge sodium load. Next is the chloride. Chloride is often called as a anion that we often forget. If we use a supraphysiological amount of chloride in our fluid, it can cause afferent arterial constriction in the kidney, which can lead to renal failure. And it has been found that when we use fluids rich in chloride, it has given rise to renal failure. Even the need of RRT has increased. Now, how the volume overload hurts? We see right from the brain down to the feet, every organ gets affected. If we can't control interstitial edema, or even if we worsen by injudicious administration of fluid, it can cause right from the delirium to pulmonary edema to renal failure. So what we will do? Instead of healing, we'll make our sick patient even sicker. Instead of improving the organ failure, we'll create more organ failure. So what is the solution to it? Before we give fluid, we should be able to answer three basic questions. Does my patient really need fluid? And if he needs fluid, what is the indication? And what is the fluid which is just perfect to be used for that indication? And we should be precisely tune that fluid according to the pathological conditions that the patient has. In our ICU, we never get a very simple patient. They're always complicated with too many organs involved. So if we just broadly divide them in three columns, what we get, there is only three indications for giving fluids, nothing else. One is resuscitation. What is resuscitation? When a patient comes in shock, be it from trauma, be it from burn, the basic problem is that the intravascular compartment is depleted. The organs are not getting perfusion. There is a gap between the oxygen demand and the oxygen supply. And our job is to give fluid to fill that compartment so that the preload gets optimized, the stroke volume gets optimized, the perfusion right to the microcirculatory level gets optimized, and this gap gets bridged and the organs are perfused well. So that is our job for resuscitation. Next is replacement. Whatever is getting lost, we have to replace. So we must know what is getting lost. What is the composition of the fluid that is getting lost? Then we have to choose from the third column and fit it. Next is the maintenance. This maintenance fluid forms the bulk of the fluid therapy in the ICU. What is a maintenance fluid? It is what is the sensible and insensible loss. And the patient is not able to take orally, or due to the disease process, the oral intake is prohibited. In that case, only we require maintenance. A patient who is able to take orally, they can compensate their fluid. We don't require an IV fluid for that reason. Another thing is very important, what we call fluid creep. What is a fluid creep? Fluid creep is the fluid that we give through our nutrition. we have patients on TPN, we are giving medicine, we are diluting it 100 ml to 50 ml. These are adding to the fluid overload, and we have seen how judiciously we have to keep that balance. And these are the additional pathology. There are often the multiple pathologies that present in the single patient. Renal function, liver function, brain, ERDS, diabetic complications, and compromised cardiac function. And here is our menu. These are the IV fluids which are available. So we have to correctly mix and match. And of course, it is not an easy job. If we broadly classify the IV fluids, these are in crystalloids and the colloids. What is the basic difference between these two? Colloids have a higher molecular weight, and if we use a synthetic colloid, it has a substitution of the sugar, which keeps it in the intravascular compartment. So if we give 1 liter of colloid, it will remain mostly in intravascular compartment. Instead, if we give crystalloid, and if we give an isotonic crystalloid, it will get distributed in the intravascular as well as interstitial, and very least amount will go to intracellular. Now, if we use a hypotonic one, it will get distributed in the 3 compartments. So, in the colloids, we again have synthetic, and we have a natural, which is albumin. In the crystalloid, now what has got our attention is the balanced salt solution. What is the difference between a saline and a balanced salt solution? Saline has only got sodium and chlorine, the 0.9% and 0.45% DNS. A balanced salt solution has got buffer, be it in the form of lactate, acetate, gluconate, and its composition closely resembles the plasma. Among the balanced salt solution, what we call a ringal lactate, Hartmann's plasmolite. Among that, ringal lactate is a little hypotonic. Stereofundin is a little hypertonic, and the plasmolite are exactly matching the plasma composition. Now we will come to know how to use them for the patient and how to modulate it according to the pathology the patients are having. Now coming to the most common category of patient, septic shock. In and out we treat this patient. There is something called a rose. What is rose? When the patient gets the first insult, when the patient gets the infection, it is the first hit. And next, there is an ischemia perfusion phase. This is the second hit. This phase can be actually called a resuscitation and optimization phase of fluid therapy. Here our job is to resuscitate the patient. That means we have to keep the intravascular compartment full and optimize the stroke volume. So we have to judiciously keep the fluid balance like that, so that the organ doesn't get hyperperfused. At the same time, there is no extra interstitial edema. What is the current recommendation? We should not give it blindly. We should have some degree of dynamic monitors, be it a pulse pressure variation, be it a cardiac output monitor, be it a stroke volume, be it an invasive, be it a non-invasive. We should get guided by something of a dynamic monitor. And second, we should start it as early as possible. The surviving sepsis guideline has reduced the bundle from 6 hours to 3 hours, and now it is a 1 hour bundle. We should start it as early as possible when we suspect that patient has a sepsis and he is in shock. So, and then it should be completed in 3 hours. And after, what will be the choice of fluid? Let us go to our menu. We have got colloid, we have got crystalloid, among that we have got saline, and we have got balanced salt solution. It is very tempting to use colloid because it will remain in the intravascular place. Why not to use it? That is our aim. But the problem is that capillary leak. This is the very dreaded problem with the septic patient. So this endothelial surface layer, the glycocalyx layer is damaged. So the colloid which we are giving, it also gets leaked out, and it will also lead to the increase in the interstitial edema. So it is very well reflected in different trials that has been done, especially the success trial, the crystal and the chest trial, where in sepsis patient we have found that the renal function has deteriorated, the patient require more RRT. So the synthetic colloid is not in the recommendation. We could see it. So what is the strong recommendation? It is that we should start fluid immediately. When it comes to the choice of fluid, again, the recommendation becomes weak because we are still a little confused. What is the problem if we use saline? It is very good. It can fill up the intravascular compartment. It is very cost effective, it is very cheap. Problem is the supraphysiologic amount of sodium and chlorine present in it. And we have already learned how it hurts the kidney. So the current recommendation is that we can use 0.9%, but when we can mix it with a balanced salt solution so that we don't give it in a very large amount, and we should keep a monitor for the sodium and chlorine. The moment we find that it is increasing, we should always keep it on check. And among the colloid, yes, we can use albumin. In various trials, like the very landmark trial SAFE, we have found that it does not increase the mortality. Actually, it doesn't cause any change if we use crystalloid or use albumin. But the benefit is that we can reach the hemodynamic goal very faster with the albumin. So when we require a very large amount of fluid, we can replace some amount of that in albumin. And there is a very interesting fact. We have got 4% albumin, we have got 20% albumin. Actually, the 4% albumin has got more chloride content, so better to use the 20%. Coming to the next common patient trauma. The basic is that scoop and run. But what do we mean by it? That means when the trauma patient is bleeding, we should not be in a hurry to give lot of fluid. Even a rapid infusion of fluid will destroy the soft clots, and it can cause the patient to bleed more. And we know the lethal triad: the bleeding, the hypothermia, the acidosis, the coagulopathy. This is a vicious cycle. So if we know that bleeding can be controlled within few hours, not more than 6 hours, of course, we can allow the patient to be a little hypotensive. How much hypotension? In case of a penetrating trauma, we can keep the SBP as low as 60-70. In case of blunt trauma, the goal will be a little higher, like in 80. But in case of a patient with traumatic brain injury, we have to keep the SBP at around 100 to 110. And always, if we are losing blood, we have to replace with the blood and blood products. And as a bridge, especially they have told before the patient gets admitted to the hospital, fluid plays a role. Yes, we can use 0.9%. We can again use balanced salt solution. This is always very safe. But we have to keep a watch. The patient has got hyperkalemia or not. Whether the patient's renal function is okay or not. Because before giving potassium containing fluid, we should be careful about it. And we should always be able to give answer to the question, does my patient require fluid? Do we have a monitor to guide us? As long as the patient is responsive to fluid, we'll give fluid. The moment patient starts not being responsive, we have to stop. So here also we require a dynamic monitor, what we commonly now call a goal-directed therapy. Now, there is a special consideration for traumatic brain injury patients. When we have done a SAFE trial, we have found in a particular group of patients, that is a trauma patient, there is a high mortality when we use albumin. And we have found in that trial that these patients are always have associated traumatic brain injury. So actually they have done a post hoc trial and they have found that TBI is of course associated with increased mortality if we use albumin. So in other case, we can replace some amount with albumin, but for a TBI patient, it is a strict no. Coming to a very common situation, our operative surgical ICU. So why do we require a patient to be on fluid? As we have already told, always before we prescribe, we always should ask ourselves the question, does my patient require a fluid? If the patient is an NPO, if the patient is a healthy patient, able to take orally, he was taking orally, he or she, before the surgery, and if the NPO is less than 8 hours, because nowadays we have reduced it even to 2 hours, they don't require fluid. And if it is longer than that, this much fluid we require, 0.5 ml per kg per hour, just to replace the sweating, the urine output, and all these things. So sensible and insensible, what we call it. Now, during surgery we require. Why do we require? Surgery is itself a process where we can induce the same type of capillary leak situation because it can cause inflammation. And it also causes damage to the glycocalyx layer and all these things. So here we will require something like resuscitation fluid. Again comes the dilemma, what fluid we should use? But again, our view is very clear. We can use 0.9%, and especially if the patient is hypochloremic, Metabolic alkalotic, why not to use it? What does a 1,9% do? It causes hyperchloremic metabolic acidosis. So we can, of course, use it in a patient which is hypochloremic and which is hyponatremic, which is having metabolic alkalosis. And even the patient with a normal sodium, we can use, but we have to be sure that we are not using it too much. So normally it has been seen that if we use it in 1 liter per day, it does not cause any deleterious effect on the kidney. Now, here also we should be goal directed. I'm again and again emphasizing on that, because what we do, we keep it at 100 ml per hour and we forget. That is not the thing. Maintenance fluid is something that should go on. And what is resuscitation fluid? It should be given depending on the fluid responsive of the patient. Suppose a patient requires 30 ml per hour. So that is going on as a balanced salt solution. Over and above, we use some monitor to determine the fluid is responsive to, the patient is responsive to fluid, and that much fluid will give. In the moment the patient is not responding, we'll stop. Again, the patient has started responding, we'll give. And at each point of time, we'll look, it is not causing any deleterious effect. That is our job in each and every indication. Now, what is the special consideration? Patient has got nasogastric suction. These are very common in post-op patient. Patient has got prolonged vomiting. They're losing acid. This patient is commonly alkalotic. Of course, 0.9% solution is the preferred decision. Now, patient has a small bowel fistula, stoma, lot of diarrhea. What we are losing? We are losing the small bowel fluids. These are rich in bicarbonate. These are rich in potassium. So RL should be the ideal. Again, RL contains potassium. We should be careful. And this is the normal content of the ileostomy, the jejunostomy and colostomy. So this much fluid, if it comes out, we have to just replace it. We don't have to panic. And we have to just know what is the composition. Now, one thing, patient often require TPN, especially the liver patients. So if the patient is requiring TPN, that much of fluid, we should keep in our calculation. Because when we're talking about fluid overload, we exactly should be able to calculate how much is the intake and how much is the output, and divided it by the admission weight and multiply it by 100. This will give us about the fluid overload of the patient. And we have found in a very old trial of soap study, it dated back to 2006, for every 1 liter increase in the fluid, it increases. If every more than 10% fluid overload, it increases the mortality. So we have to be take into account whatever fluid is going to the patient, be it TPN, be it medicine. Now coming to the neurosurgery patient, tonicity is very important. Why? Because if we give a hypotonic fluid to the neurosurgery patient, it will cause the cerebral edema. So here our choice will be 0.9% saline. Even we can use 3% if there is an increase in ICT. Now, these are the associated pathology which are present with the sepsis or the trauma very commonly. Kidney is a very special organ. It is an encapsulated organ. So it tolerates the venous congestion very poorly. So, and at the same time, we have already learned that if we increase the chloride content, it will cause the apparent arterial constriction. So, in that case, the kidney's perfusion will suffer and it will go into failure. So, while giving NS, we should keep a watch on the sodium and the chlorine, and we should also keep a watch on hyperkalemia and hyponatremia, because these patients who are in a chronic kidney patients, they have a reduced ability to concentrate and the dilute. So we have to keep a close watch on the potassium and sodium and adjust the fluid accordingly. Coming to the direct liver function. Liver is another special organ. The problem is that there is a total extracellular fluid overload in the face of central effective circulating hypovolemia. The problem is that they also retain the sodium. So there could be hypovolemic or hypervolemic hyponatremia. So if it is hypovolemic, there is no problem. We can use 0.9%, keeping a watch on sodium. And they often require dextrose containing because they are prone to develop hypoglycemia. Balanced salt solution is good, like Plasma-Lite or stereofundin. They almost always they are close to the plasma composition. And albumin. This albumin has a very special role in liver. They are found to be very helpful in spontaneous bacterial peritonitis, large volume paracentesis and HRS, because they prevent the cardiac decompensation by keeping the stroke volume low. Coming to ERDS, very commonly associated with trauma with sepsis. Subtype of ERDS we have come to know more in the case of COVID-19. We have type L and type H. Type L, we have got less edema, less problem with the elastance in age. The opposite is true, that is the classical ERDS. In the second type, we require more fluid, so we have to just follow the rules and have to just follow the surviving sepsis guideline type of thing. The phases are also the same, and we have to be careful about it. And once after initial resuscitation phase is over, then we should keep only the replacement and the maintenance. One, the Parkland formula, we all know about it, and but it often underestimates. So we have to take care about the extent of the burn and whether it is deeper burn or not. And last is the diabetic emergency. Huge amount of fluid deficit. From 3 to 5 liter, it can go up to 9 to 12 liter. Of course, in case of a high blood glucose, we have to always see the corrected sodium. If the corrected sodium is high or normal, then we can use a hypotonic one. And if it is low, we can use 0.9%. And we should always be very careful that we don't cross the limit of 3 millimole per liter, per kg per hour of the change of the osmolality. And there's also a very interesting fact that in different trials, we have found that even if instead of the saline, if we use the balanced salt solution and the ringal lactate, we could correct the acidosis quickly. So we can judiciously combine these two. The starch do not have much role in it, also the albumin. So with this much of discussion, we hope that we will be careful while we prescribe the fluid next time, and we should always ask the 3 important questions, and we'll prescribe the fluid accordingly. Thank you.